for diagnosing congestive heart failure, which it isn't. It's far too common that that happens. So, what is CHF? It's a clinical syndrome, okay? And it's diagnosed by history and physical exam. There are specific symptoms, dyspnea, fatigue, and signs, edema and rales on the physical exam. That impairs the ability of the ventricle to fill with and eject blood. So the things that are important here is there's no single diagnostic test because it's a clinical diagnosis. However, the chest x-ray labs are very useful, but they merely help to confirm or rule out certain diagnoses. And the next point is very important to coders and people who submit bills. It's important to know that heart failure is not equivalent to cardiomyopathy or systolic dysfunction. For example, if I had a guy with an ejection fraction of 10 or 15% comes in the hospital, he could be totally compensated and actually dehydrated. He does not have a diagnosis of congestive heart failure. And I see that far too often. So, anyway, moving along, those things, cardiomyopathy or systolic dysfunction, those are the functional structural reasons for the person having them, the episode of heart failure, but they aren't consistent with the diagnosis. And lastly, heart failure. Are we getting the whole screen here? Heart failure is a more appropriate term than congestive heart failure because not all patients are volume overloaded when they come in, but they can still be in heart failure. And there are different types of heart failure, and we'll talk about this in a little bit. This situation can occur in the setting of acute cardiogenic pulmonary edema. For example, patient you've probably heard of flash pulmonary edema. Patient may have a sudden heart attack, massive heart attack, and just going to florid pulmonary edema, and yet they're actually dehydrated. So what do? Their oxygen's low. What's the treatment? You don't diurese them. They're already dehydrated. You put them on a ventilator. Afterward, reduce some oxygen. So anyway, so heart failure is the more appropriate term. This is talking about symptoms and signs of heart failure. Obviously, dyspnea on exertion, shortness of breath when you lay down, waking up at night short of breath, edema, fatigue. And then we have two kinds of heart failure. Left ventricular, okay? Because the left ventricle pumps blood from the lungs to the body, so you end up getting crackles or rales, and S3 or S4 due to the congestion of the ventricle. And signs of peripheral hypoperfusion, that's important. A lot of people overlook that. You have cold cyanotic toes and fingers. It's a sign of poor pump function. Okay, very, very specific actually. Right ventricular. Right ventricle pumps blood from the body to the lungs. So if it can't do its job, you get edema, jugular venous distension, hepatic congestion, and swelling in the legs. Okay. Now we're going to talk about some normal chest x-rays. Okay. So obviously, here's the heart. These are the lungs. Notice that these angles here are quite crisp. You can see the heart is small. And we call this the vascular pedicle. This is the aorta on this side, and this is the SVC, the vena cava over here. So if this is really wide, that tells us what the fluid status is. Okay? Go to the next slide there. There's a little more anatomy. You just see the border of the left ventricle over here. This is the right ventricle superimposed on the left ventricle, obviously. Aorta, pulmonary veins. And then here shows you this is the right atrium, the border of the right atrium over here on this side. You have the pulmonary artery right here, and this is the superior vena cava, and that's the aortic knob right there. Another example of normal chest X-ray, I put this one in so you can see the normal position of the trachea is just to the right of the midline. Just to the right of the midline. Okay, so pulmonary edema. Two types of pulmonary edema. We have cardiogenic pulmonary edema, which is a structural or functional, caused by a structural or functional problem with the heart, okay? So that you increase hydrostatic pulmonary capillary pressure. And this could be acute, like in the setting of a massive MI, okay? Or they may have chronic congestive failure, and they just kind of accumulate fluid slowly over time, usually from dietary indiscretion or something like this. Excuse me. Dr. Knight. Yeah, that's fine. Go ahead and give Dr. Knight. That's fine. Okay? All right, that's good. Okay. So, moving along to non-cardiogenic pulmonary edema. Obviously, that's pulmonary edema from other causes. Probably the most well-known one that we're going to kind of focus on is acute respiratory distress syndrome. Here we have a severe infection, sepsis, and you've got an inflammatory systemic reaction that causes capillary leak everywhere, particularly in the lungs, which then fill up fluid into the alveoli. So, kind of going into cardiogenic pulmonary edema in more detail, you can look at it in 3 stages. First stage is sometimes referred to as redistribution. Second one, interstitial edema, and the last one, alveolar edema. What we see here is in the redistribution stage, this is the pressure, the wedge pressure in the pulmonary capillaries, 13 to 18. Anyway, first thing you see is increased heart size, which is defined as a cardiothoracic, ratio of greater than 50% on the chest X-ray. And you'll see cephalization of flow, and that's where the veins are more dilated in the upper lung zones than they are in the lower lung zones. I'll talk more about that later. And again, that vascular pedicle I was telling you about, the aorta and the superior vena cava, when that's wide, that's telling you there's a lot of fluid in the lungs. Then what you start to see is interstitial edema, where you have a lot of thickened septal lines throughout the lungs. They're sometimes referred to as curly lines. Well, you'll see pictures of that. Parabronchial cuffing, where you can actually see the bronchi on end sometimes on a chest X-ray, and the walls will be really thick. And then, of course, there's this, when you look at a chest X-ray, sometimes you can see the vessels, the pulmonary arteries and veins. Those become very indistinct. And moving along to the last stage, this is where it's really more advanced heart failure, when you start to see consolidation and patchy cotton wool looking, what we call alveolar infiltrates. The alveoli are just filling up with fluid. And when that happens, that kind of outlines the bronchi so that you can see, the actual bronchus. We call those air bronchograms. So there'll be a picture of that for sure. So the limitations of the chest X-ray and looking at all this edema is, first of all, you may not even see the edema until the total amount of lung water increases by 30%. And also, obviously, you can't distinguish edema from blood or pus, like in pneumonia or some kind of hemorrhagic pneumonitis. Sometimes this can look like heart failure. So here's that vascular indistinctness. Here you can see there's a vessel right here, okay, and it's fairly sharp. Over here, it's kind of fuzzy and hazy. You really can't see. There's all these little septi in here that are getting swollen up with fluid. This is that parabronchial cuffing. There you can see a bronchus on end, and you see how the walls are thickened there. And over here, after they've diuresed it a little bit, it's not quite as prominent. This is kind of a bigger model of the parabronchial cuffing. Obviously, this is the edematous one, and that's not. This is another example of the septal lines, or those curly lines. They kind of absorb water and get swollen, so you see all these lines in here. They call them curly B lines when they're down in the base of the lung and they're parallel to the pleura. Just kind of a fancy term, I guess. There are other curly lines, but basically it's the same concept. They're just septations in the lung that become edematous, and you can see them on the X-ray. So we talked about that cephalization of flow, where the arteries, the pulmonary veins are more dilated in the upper lung fields, and it used to be felt that this was pretty sensitive for acute pulmonary edema, but now we're finding that this is really more of a chronic thing, and it's not distended pulmonary arteries, it's pulmonary veins. And here's an example of it. I don't know if you can see it very well, but that pulmonary vein is pretty dilated in comparison to anything you see down here. We've got another picture that might be better. There's another picture of cephalization flow. You kind of see these vascular structures up here that are just at least as prominent as the ones down in the bases of the lungs. It's a finding of chronicity. And we talked about the vascular pedicle already. Here's a dilated vascular pedicle, and then here's normal. Okay, so I told you there was acute and chronic cardiogenic pulmonary edema. Here's a really good picture of chronic cardiogenic pulmonary edema. It's got pretty much everything. These alveolar, fluffy-looking infiltrates, this large heart, this very dilated pedicle. You can probably find some interstitial findings in there as well. You compare that to acute cardiogenic pulmonary edema, this patient that just had an MI. You see the heart is not so big. You see the pedicle is not that dilated, but you're seeing all these fluffy alveolar infiltrates, so that's pretty severe pulmonary edema. And here are these little septal lines. You see those as well. Another example of acute cardiogenic pulmonary edema, but in this case, what we're seeing is really more just these, this what we call interstitial edema. You're seeing just all these septations and lines everywhere. You're not seeing those fluffy alveolar cotton wool looking infiltrates, okay? But it's acute because the heart's not that, it's not that big, and the pedicle's not that big. And this is pretty severe, but this is a case of chronic, large heart, dilated pedicle. You've got interstitial and alveolar edema. Yeah, they always talk about this classic bat wing pattern of alveolar edema. Sometimes you see it in flash pulmonary edema where it's just right there in the hilar areas, and it looks like a bat's wing. This is not a real good picture, but when you hear that term, that's what they're talking about. Now I'm going to go into non-cardiogenic pulmonary edema. And it's basically alveolar fluid accumulation without any hemodynamic compromise to suggest a cardiogenic etiology. Most common causes, ARDS, HAPE, high altitude pulmonary edema, neurologic pulmonary edema. Any acute neurologic event can sometimes cause an adrenergic release, and that can affect the lungs in such a way that fluid can accumulate and cause edema.
So I saw twice in the recovery room, some young men in particular being extubated, and they thought it was, the extubation was too rapid, and they called it neurogenic pulmonary edema. Is that what you would call that?
No. If they were
So they were in there.
extubated too quickly.
Yeah, they said the pressure, because of the, as they were extubating, the intrathoracic pressures changed too quickly.
What that could be is laryngospasm, and you know, sometimes if they have swelling of the trachea, or maybe just swelling of the trachea because they were intubated, or maybe it was traumatic intubation or something. And if there's a lot of swelling, all of a sudden they're trying to breathe and they can't get any air in, so they develop this negative pressure pulmonary edema. Yeah. So this is what you're describing kind of sounds more like that. And a re-expansion pulmonary edema, that's where, you know, you tap somebody's thoracic pleural effusion and their lungs re-expand so rapidly that they start weeping fluid, and you've got a little bit of an issue there. Okay, so this is an example of non-cardiogenic pulmonary edema. Okay, this is obviously ARDS. You see the heart is normal in size, the pedicle is normal in size, and what you notice is you have all these kind of, again, the fluffy cotton wool looking infiltrates. You don't see curly lines, you don't see the septal thickening. And it is rather diffuse. When we were looking at chronic cardiogenic pulmonary edema, we noticed, if the patient was standing when the x-ray was taken, that it was denser in the bases. This is just kind of diffuse throughout. Okay. So here's another comparison that I was talking about. Here's cardiogenic. This is supposed to act, this actually is denser down here in the bases. I don't know if you can appreciate it on this projection. So this is the cardiogenic pulmonary edema, large heart, large pedicle. You've got interstitial edema and maybe a little patchy alveolar edema. And here's ARDS. It's pretty severe. You've got all these diffuse patchy cotton wool infiltrates everywhere. You can't even really make the heart out, but it obviously is not very big. And so you don't see the evidence of the volume overload or anything. You just see the pulmonary edema. So this just kind of sums up some of the things we've been talking about with cardiogenic edema, septal lines, parabronchial cuffing, pleural effusions, this vascular redistribution, the cephalization of flow, the wide vascular pedicle, and a large heart size. You see all those things in cardiogenic pulmonary edema. This is a little error here. It is present when you have alveolar edema. When you have real severe cardiogenic edema, you do have air bronchograms. We'll see a picture of that. In non-cardiogenic edema, you don't see septal lines, parabronchial cuffing, pleural effusions. You generally you don't see this vascular redistribution because you're not looking at a volume overload state. Of course, not to say that somebody that's in heart failure can't get septic, right? So obviously, there are many combinations that you can get with this. So. Oh, time for a quiz.
Oh.
Okay.
Refer to Christy.
So, on these slides, tell me what you think the heart size is, the pedicle size, where you think it's cardiogenic or non-cardiogenic, and we'll just go from there. What do you think that is? Is the heart big?
Yes.
Not so much. And this is a tough one, okay? This one was really hard because everything is so obscured by these patchy infiltrates. So that's not a fair question. So, but actually, So if I tell you that the heart's not big and that this pedicle is not wide, what is this? Non-cardiogenic. Yeah, you don't see any of that scratchy looking interstitial edema, right? You just see these patchy pulmonary infiltrates. So this is ARDS. Okay. What is this? Is the heart large?
Yes.
Not so much. I'm sorry. It's,
That's okay. We'll
yeah.
get it right, yeah. That's right.
Yeah, well, I mean, it's maybe around 50% of the, cardiothoracic shadow. Also, this is, I forgot to tell you, this is an anterior-posterior view. So the heart is farther away from the X-ray plate. So the projection of the heart is actually larger, as opposed to posterior-anterior, PA, where the heart's right up next to the plate, and so the projection of the heart is smaller. So, tricked you again. Anyway, so this is
Yes, till I get it right.
this is another, and do you see, well, the pedicle's not very big, right?
That's true.
Oh, do you see any septal lines or interstitial edema? No. So, I just see these patchy cotton wool infiltrates. I'm saying this heart is small because this is an AP film. I'm saying the pedicle is small. So again, we have a non-cardiogenic pulmonary edema. Could be ARDS. I can't see my notes on the screen for some reason. But anyway, non-cardiogenic pulmonary edema. What is that? Let's see. So is the heart bigger than 50% of the thoracic diameter? It's right about at 50.
Close, yeah.
So I would say it's probably not enlarged. Another clue, is this pedicle enlarged?
Yes, looks like it.
Not so much.
No?
Not so much.
So it's not bulging right there, or is that normal on the right hand
Yeah,
side?
right up.
Oh, this is the aortic knob.
Oh.
This is the aortic knob. But this isn't that wide, especially not for that heart size. You just got to look at a lot of these. This it's kind of.
Well, this is kind of fun.
It is fun.
Okay, so this heart is, it's not really large, this pedicle's not really big. What kind of infiltrates are we seeing here? How would you describe those? Well, obviously there's some patchy cotton wool looking ones, right?
I don't know.
But do you see any kind of little lines in
Yeah,
here?
yeah, feel fibers.
I think it looks a little scratchy in there, doesn't it?
Yeah.
Okay, so what does that tell you? You don't see that in ARDS, right? So this is cardiogenic, right? Well, if the pedicle's not dilated and the heart's not dilated, is it? And I don't see any cephalization, any dilated vascular structures up here. So is it acute or chronic? This is acute cardiogenic pulmonary edema. This is somebody who just had a huge heart attack. And what's interesting is one of the main points, acute cardiogenic pulmonary edema looks just like non-cardiogenic pulmonary edema, with the exception of the curly lines and the parabronchial cuffing, which I don't even know if I can find that for you there. So that's the only difference between the two. So they look very similar. Just remember that one thing. Acute cardiogenic pulmonary edema, okay, flash pulmonary edema, some people call it, looks just like non-cardiogenic pulmonary edema or ARDS, with the exception of the curly lines, the septal lines, right?
And that means interstitial swelling.
Interstitial, right. We don't really see the interstitial edema in ARDS so much. Now, like I said, there are caveats, right? I mean, you can have heart failure, you get pneumonia, you get septic, right?
Yeah.
Right? Okay, so. hell, what in the world is this? This is pretty hard looking at these heart, but I don't think this heart is more than 50%, do you? I don't think it is.
I would have until you had just taught us that, because I would have.
I know, right?
That 50%.
I know, some of these
that-
x-rays are,
But that helps though, because I would have thought that was, yeah, that.
and I'm gonna tell you, that really does look wide, that pedicle, but I'm gonna just say for the purposes of this slide, that it isn't,
Okay.
okay? All right. Now, what kind of infiltrates do I have here? It's really hard to tell. I mean, it's just kind of diffuse. I don't really appreciate any of that interstitial, scratchy looking stuff. So we're going to say that this is kind of a diffuse, patchy pulmonary edema. So this is what?
Where is diaphragm on the left? Diaphragm on the left side.
Oh, yeah, this is gastric bubble.
Okay.
Gastric bubble.
Gastric, colon.
Stomach. Stomach. That's the stomach right there, right under the diaphragm. Liver's over here.
That's what I'm-
This is right side, that's the left side. So, okay. So